Welcome to our reboot of Unremarkable Labs. We plan to be a little bit more active this year than we've been able to be in the past year. We're going to start out today with a case that is not about trying to make a diagnosis, but rather how to manage a complicated patient. I hope you enjoy it. Obviously, I'm Bob Centor again. And joining me, as always, is Dr. Natasha Mehra, who started out doing this as a resident and is now a junior faculty member and doing a great job here at UAB. We had a patient transferred to our service from an outside hospital. He was in his 60s, very complicated story. He had a one-year diagnosis of esophageal cancer, but he came to us because he had just had a biliary drain placed. He apparently has metastases to his biliary tract, was sick for about 5 days before he came to see us, including what might have been an episode of sepsis. He really came in first for scleral icterus. He hadn't been eating much. But after the biliary drain treatment, biliary drain placement, they sent him to our hospital for further management. We go in to examine him, and he's in pain. He has some drainage coming out of his biliary tract. He's very short of breath, and it's using accessory muscles of respiration. Otherwise, nothing remarkable on his exam. We then go back to the room, and he had just come over early that morning. We'd ordered labs, and the labs started coming back. And what we're going to do is, given his severe shortness of breath, oxygen requirement, look at some labs and try to interpret all of these labs so that we can better manage this patient over the next week. We were able to successfully send him home after approximately a week without oxygen and really doing well. His sodium was 147. His potassium was 3.5. His chloride was 110. His bicarb was 31. His BUN was 13, but his creatinine was 0.2. So at this point, several things seem to be fairly clear. Number one, he's slightly dehydrated. Any sodium above about 143, 144 suggests some dehydration. At the time, he was not taking oral fluids in very well. 147 is not scary. We didn't do much about that, and that just resolved with him eating and drinking. His potassium is 3.5, a little bit on the low side, but not at a level that overly concerned us. We repleted his potassium quite easily. His chloride of 110 and bicarb of 31 showed that he had very low anion gap, which made sense because he ended up having a low albumin. But that bicarb of 31 was the first thing that bothered us. When I see a bicarb that's elevated, I ask myself, is this a problem of metabolic alkalosis, or is this a compensation for respiratory acidosis? We had access to his previous labs, and he had never had an elevated bicarb before this complex previous history. And we thought there was a possibility that this could be volume contraction and metabolic alkalosis. He was working quite hard to breathe, but we just wanted to be sure that he wasn't retaining CO2. He'd had a previous blood gas that did not show any CO2 retention, and he did not have a history of COPD, yet we still got a VBG. And the venous blood gas, therefore, gave us a real clue about what was going on with him. His pH was 7.36. His PCO2 was 57. The PO2 is 34, but remember it's a venous gas, and his bicarb was 32, essentially the same number. Now that documented that we were dealing with a respiratory acidosis and that the elevated bicarb was secondary to his hyperventilation. Watching this and the terms hyperventilation and hypoventilation confuse you, I was taught back in 1973 by this wonderful pulmonary physician that to understand ventilation, you only have to understand PCO2. That the definition of hypoventilation is an elevated PCO2. The definition of hyperventilation is a decreased PCO2. You can be tachypnic, and he was a bit tachypnic, and still have hypoventilation. You can be tachypnic and have normal ventilation. It all depends upon how large your tidal volume is. So now this guy's hypoventilating. We're trying to figure out why. And fortunately, our hospital allows you to either order a basic metabolic panel, which I gave you before, or a renal function panel. And unbeknownst to me, I was taught by the house staff that even though there are more things in the renal function panel, it's cheaper. I have no idea why. But the renal function panel also includes magnesium and phosphate. Well, he had a normal magnesium, but he had a phosphate of 1.1. We felt that that phosphate was the cause of his hypoventilation. That's a known complication. And so I'm going to use this to go over the known severe complications of hypophosphatemia. We really get scared when it gets down to 1. And since 1.1 is not that much different than 1, we thought that that was enough where he had a decrease in ATP. When he came into the other hospital, he had had a normal phosphate, but he'd not been eating. During this time, he was getting glucose, and so this is a refeeding syndrome. There's a classic refeeding syndrome that did not occur on a previous measure of his phosphate, but now we have that. So there's 5 things that I worry about when someone gets severe hypophosphatemia, and I'll go through these one at a time. The first is abnormal brain findings. So patients can die from seizures because of the lack of ATP. They also can have significant altered mental status. And at times he had an abnormal mental status. They looked for encephalopathy. They checked an ammonia, but they had not checked a phosphate during the time that he was a bit altered. The next thing is the heart. I unfortunately proceeded on a M&M conference of a patient who died of severe hypophosphatemia. Came in, he was drinking a lot of alcohol. The resident had ordered a phosphate stat, but there was confusion in the lab. It did not get done stat. When they finally called up with a phosphate of 0.7, the patient was in VFib. So you can get VTAC, VFib, a variety of arrhythmias. It can also lead to heart failure because you need ATP to contract muscles. So anything that has to do with muscles is going to be impaired if you don't have enough phosphate. Then the lungs, which is what we think was going on with this man, is the problem is that hypophosphatemia, you need muscles in order to breathe, and his muscles, he was doing his best to make his muscles work, but they weren't effective because he didn't have enough ATP. The next thing is the muscles themselves can have problems, and you can get rhabdomyolysis and acute tubular necrosis, secondary acute tubular necrosis. All of those make sense from our simple understanding of ATP. The last two, I can't explain real well, maybe someone else can, and those are hematological. So it can cause hemolysis. Apparently you need ATP to maintain cell membranes. And white cells don't function as well. And so these patients are more prone towards infection. So always think about those things. I start treating once the phosphate gets below 2 for certain and maybe 2.5. I try to treat aggressively when we get back to 1.1. In this case, we were able to increase his phosphate over the next couple of days. He got progressively brighter, had more energy, and over the next 2 days, we were able to stop his oxygen. All the rest of his labs seemed to improve. Now, that gets us to all the labs I wanted to talk about, except this wild creatinine of 0.2. I think that's the lowest creatinine I've ever seen. He was not, he hadn't lost a lot of muscle mass from his cancer, which sometimes you see with very low creatinines. Perhaps the reason is because he didn't have ATP, he wasn't breaking down muscle as well, and so therefore his creatinine was much lower. It went up over the next couple of days to what probably is where he normally lives at about 0.5. But because of this, because we really didn't know what his renal function was and couldn't believe anything at 0.2, we got a cystatin C. I'm fortunate to work in a hospital where cystatin C can be done immediately. And when we got the cystatin C, it was 0.8, which is totally normal and leads to a normal GFR. We thought that there was not a problem, although he had a bump in his creatinine when he was first felt to be septic. And I just wanted to be sure that there was not a dissociation between the creatinine and the cystatin C. So that's sort of our case. I'm going to ask Natasha now if she has any questions or any comments about what I just presented.
So do you think we should routinely be checking renal function panels? I have made it my practice to start adding a magnesium. I know at least at UAB, the renal function panel, you still have to manually add magnesium, but it does include a phos. Do you think that that's something we should shift towards? Because I've found that when you go looking for electrolyte abnormalities, you typically find them.
Yeah, so at the VA, they automatically include both magnesium and phos.
That's great.
And my team and my residents said they had stopped ordering basic metabolic panels and looked at the renal function panel because you got those 2 extra electrolytes. Magnesium is sort of confusing, and maybe we'll do an unremarkable labs on magnesium and hypomagnesemia sometime in the near future. It can be really confusing because it's also intracellular, and you can be magnesium depleted and have a normal magnesium. And so we have to take that into consideration. But yes, when I'm at the VA now, I ask my teams to order renal function panels rather than basic metabolic panels, so we can get the MAG and get the FOS. And in this case, I think that we may have saved his lifetime by knowing what his phosphate was, because it would keep going down if we didn't do anything. And he really improved a great deal and was able to go home. He still has a bad prognosis, but he was very happy to be able to go home and spend time with his family. He accepted his prognosis, and oncology is following. But what we did is we gave him great palliation, being able to go home without oxygen in the meantime.
When you said that he was getting glucose, was he getting D5 through an IV, or was he being?
I think he was getting D5 through an IV. I don't remember exactly. He was getting some kind of nutrition, but he wasn't eating. He wasn't eating for quite some time because of the biliary obstruction.
Makes sense. I guess over time that can definitely be dangerous as well if you're not doing TPN versus oral nutrition.
And as we'll probably discuss on several of these in the future, anybody who's susceptible to refeeding syndrome also is almost certainly thiamine deficient. And so we've gotten to the point where we just empirically give almost everybody thiamine because it has so many complications, which we'll try to address in a future one.
And that's something I've learned for you and incorporated in my practice.
So please let us know if you like this format. If you have any interesting cases that you'd like us to discuss, we'd be more than glad to have you email us. And thank you so much for watching our discussion of this patient with severe hypophosphatemia.